people continue to trickle in, maybe I'll do the welcome and a little bit of background. So let me say, welcome everybody. I'm Jeffrey Kahn. I'm director of the Berman Institute of Bioethics here at Johns Hopkins. It's really a great privilege and pleasure to welcome you all to this jointly sponsored symposium between the Berman Institute and the Hospital for Special Surgery in New York. I've been practicing how to say that for days and days. It doesn't trip off the tongue. The S's together make it really hard. I don't know if I do that. So let me say a few words about the Robert H. Levi Leadership Symposium, which this is part of a continuing series. The Robert H. Levi Leadership Program in Bioethics and Health Policy was established by a gift from the Levi family in 1997 in honor of the late Robert H. Levi, who, as an alumnus of Johns Hopkins and a trustee of both the Johns Hopkins University and Johns Hopkins Hospital, played a major role here at Hopkins for more than 3 decades prior to his death in 1995. He was president of the Hecht Company, those of you from the Mid-Atlantic will know Hecht department stores, and a civic leader and philanthropist. In addition to being instrumental in the revitalization of downtown Baltimore and serving on the boards of many of Baltimore's institutions, Mr. Levi was a patron of the arts. He gave generously to the Baltimore Symphony Orchestra and to the Baltimore Museum of Art. You may know that the BMA Sculpture Garden is named for Bob and his wife. Baltimore and Johns Hopkins benefited greatly from his extraordinary vision and his deep personal commitment to both Johns Hopkins and to the city of Baltimore. In the obituary, when Mr. Levi died on February 21st of 1995, the Baltimore Sun observed that, quote, his adult years were one long crusade of giving and giving back, end quote, and that he made sure that his donations were put to good use. In short, he cared about making a difference. As did his wife, Rida Hecht Levi, who was at the forefront of both resisting and then working to change the social norms of the 1950s in Baltimore that included barriers of race, religion, and social class. She left a truly lasting impact on this community. The goal of the Robert H. Levi Leadership Program is to raise the level of ethical discourse about critical issues in medicine and social policy. So we're here today. It was on stage, both in the community and among those who have the practical responsibility for addressing them through a public event on a current topic of importance to our nation. And so we are honored to have the Levi name associated with these symposia. While members of the Levi family are not able to attend today, they ask that I send their warm wishes. So thank you all for being here. It's my pleasure now to ask my colleague Travis Reeder to come to the podium and introduce today's program.
Thank you, Jeff. Appreciate you being here. Thank you all for coming. So this event is actually about a day-and-a-half event. So there are several folks, many of whom are in the room, who are going to join us for a working group tomorrow. And so this is a bit of a kickoff event, and we are tackling a very hard problem, thinking about ethics and opioids in the context of orthopedic surgery. And I want to talk a bit here at the beginning about the role of ethics in this conversation, because you could absolutely go to a medical conference and just talk about prescribing, and just talk about medicine, opioids in the context of surgery or anything else. I'm going to start off by acknowledging my other co-organizers for this event. So as Jeff said, this is jointly sponsored. The Berman Institute, the Department of Orthopedic Surgery, the Hospital for Special Surgery. Dr. Waldman on stage is here representing them, along with some of his colleagues. But also co-organizers from Hopkins here, Dr. Casey Humbert, Dr. Ali Dunham, and Dr. Babar Shafiq, all have put in a huge amount of work to make this possible, and they'll be doing most of their work tomorrow. Since you don't get to see it, I'll just embarrass them now and say they've been doing a really amazing job. So what I'm going to do now is I'm going to say just like 10 minutes worth of stage setting. And I think there's some of it that most people in the room don't need, but I want to make really vivid the nature of the problem. And then the part that might be a little bit new is I'm a philosopher by training, and my appointment here is at the Berman Institute of Bioethics. I'm a bioethicist by profession. And it's not always obvious what I do in this conversation. Oh, it's a very sensitive screen. Sorry about that. So like I said, you could have the conversation about opioid prescribing just in the context of a medical conference. So why are we doing ethics and opioids and orthopedic surgery? And I take it the answer is something like the following, that we want to have a deeper conversation than you might otherwise have. We want to have a conversation about what responsible opioid prescribing looks like against the backdrop of an unprecedented, really deadly drug overdose crisis. So what does it mean to be a responsible clinician who has a DEA license to prescribe these substances? What does it mean to be a good doctor or a good nurse practitioner or a good PA in this context? So that's the kind of right at the front ethics lens that I want to impose here. And I want to catch you all up. So really kind of two components in the next few minutes. Make vivid the severity of the problem that we're facing, and then make a little bit more clear my lens that I bring to this conversation as an emphasis. And then the rest of my role here is going to be moderating. These are world-class experts on this topic, and we've been super fortunate. I was hoping we would get one, maybe two. All four of them came. How lucky for us. So I hope this will be very edifying. So I imagine everybody in the room knows that we're in the midst of a really bad drug overdose crisis. I imagine that even in this room, some of the things I'm about to say will make your head explode just a little bit. Okay, so let's get a sense of the scale of the problem. 2017 is the last year in which we have finalized overdose death numbers. We have pretty close to finalized numbers for 2018. I don't use them yet until we've really decided that they're final. So in 2017, here's what happened. 70,000 and change people died from drug overdose. And 68% of those involved opioids. So 48,000 people died from drug overdose that involved opioids. Humans are really bad at big numbers. We're really bad at holding in our mind what that sort of thing means. And so I want to give you context for this statistic so that we can kind of understand just how angsty we should be about these facts, right? In 2017, 40,000 people died from auto accidents, and 39,000 people died from guns. So more people died from overdoses that involved opioids than either of those. And you add them together, and it only barely exceeds the number of people who died from drug overdose in general. Now let's get some broader context. The AIDS death rate peaked in 1995. That was the worst year on record. And in 1995, 43,000 people died from AIDS. So more people died in 2017 just from opioid-involved overdose than ever died in a single year from AIDS. One more. Number of people who died on the American side in the entire Vietnam War, 58,200. So more people died in just 1 year from drug overdose than died in the entire Vietnam War. Think about the degree to which it led us to march in the streets, to be angry, to demand change. And more people are dying every single year. So that's the scale. Now let's talk a little bit about how we got here and what it looks like. This is a very famous graph. This is the CDC's update from the last year, where they tried to assign weights to the drug overdose epidemic to show a few things. So here's what I want to show, and this is really crucial for understanding what I'm calling the ethics frame on the drug overdose crisis. The reason it's really crucial is because it's not just that prescribing has impacted the drug overdose epidemic in one way, it's affected it in multiple ways that are sometimes in tension with one another. So I'll come back and try to make that clear. So the purple line on the top of this graph, that is the overdose death rate from prescription opioids. So overdoses that involve prescription opioids. And between 1999 and 2010, that number quadrupled. So during that same time, from 1999 to 2010, the volume of opioids prescribed quadrupled. So we had a 400% increase in the number of pills that are going out on the streets and a 400% increase in the overdose deaths. It was really hard to deny that clinicians' prescribing patterns were contributing to an emerging overdose epidemic. But the story doesn't end there, and this is a really important piece for any conversation like the one that we're going to have. Because starting about 2007, 8, 9, 10, and certainly beyond, the country started freaking out because we were prescribing a lot of pills that were then killing a lot of people. And so you started having these conversations like, we have to stop prescribing so many opioids because they're killing so many people. And you had people like the director of the CDC, then director, Thomas Frieden, saying, look, the prescription opioid problem is at least partially doctor-driven. We can solve it partially by doctors' actions. So all of a sudden, a bunch of responsibility was laid on the shoulders of clinicians saying, look, you did this, fix it, stop killing your patients. And it worked in a really limited way. Because right around 2010, 2011, about the time that we were curbing the supply of prescription opioids by scaring clinicians into not prescribing, we start to see a tick down in overdose deaths involving prescription opioids. But it's not a completely happy story, because what happens at that exact same time? Overdose death rate from heroin shoots up. What's the reason? The data by itself doesn't tell us, but you start doing other studies and talking to people who use drugs, and the story emerges pretty clearly. We drove a class of people with opioid use disorder who had access to prescription opioids to the more dangerous illicit drugs of the black market. So you take away, you put a restriction on the prescription supply, and people who have a health condition defined by cravings, compulsions, willingness to act even in the face of negative consequences. That is to say, people who have an addiction, some of them will be willing to go to the black market even if it's riskier. So heroin death rate goes up, and then something even worse happens, which is drug dealers see a profit opportunity. There's a huge surge in demand for heroin, so make it more potent. Make it more profitable by cutting it with really powerful synthetic drugs and then packing a bunch of baby powder or whatever other garbage in there and selling it for the same amount using fentanyl analogs. So for those who don't know, fentanyl can be 100 times more potent than morphine. Carfentanil, one of its most potent analogs, 10,000 times more potent than morphine. We use it to sedate large mammals like elephants. And we found it in the heroin supply. Some in Vancouver, we found it in Philly, at least for one outbreak. So even carfentanil is being cut in the heroin supply. So within 3 years of the heroin demand going up, the heroin overdose death rate going up, the fentanyl overdose death rate shoots up. So why am I telling you this history and focusing on these 3 waves that the CDC is talking about? Because there's more than one moral burden on clinicians right now. One is the one that Thomas Frieden was trying to get at, which is don't recklessly prescribe opioids. If you give out too many, it can contribute to a glut in supply that can cause damage. But the other is, if you cut people off abruptly from their supply, they might turn to a much more dangerous supply in the black market. Heroin is cheap and widely available, and now available everywhere in the US, which it didn't used to be. You used to have to go into cities to get it. Now you can get it in every small town in Indiana, where I'm from. Okay, so what's that history doing? Here's the very kind of simple takeaway that I want to put up from that fairly complicated recent history. Perhaps the most useless graph I'll ever put up, but I hope it sears in your mind. It's kind of a cartoon spectrum. We can have a broad set of attitudes about opioids. And on one end, you can have a prohibitionist attitude. Lots of people are adopting this these days. We've also been here before. There's a longer history that I give in longer talks that's super interesting, but for the majority of the 20th century, for half of the 20th century, we just thought opioids were evil. And we had a really hard time using them. And it took a lot of sustained work even to kind of crack into the medical community and say even those who are suffering with end-stage cancer ought to be allowed to use morphine rather than suffering because we're afraid they'll get addicted. So you could be a prohibitionist, but when we do that, a lot of people suffer. What we're going to talk about today is we're going to talk about orthopedic surgery. We got a couple surgeons on stage, lots in the audience. I don't mean to be mean, but you all cause a lot of pain. Like knives and hammers and saws. I mean, it's like biological carpentry, as far as I can tell. Philosopher here. So we might want opioids if they're really effective, and other things aren't as effective, right? But then you could also have a drugs for everyone mentality, and we've tried this one pretty recently too. Starting in the mid to late 90s, up to about 2007, 2008, and slowly tapering off. It was, opioids are the pill for nearly every pain. They're safe and effective not only for severe pain, but for moderate to severe pain. You have a mild sports injury, you fell off a ladder, you have a sprain, here's some oxycodone, right? Drugs for everyone got us into a lot of trouble. Again, if you look at the history, more than just now. This happened at the turn of the 19th and 20th century as well when Bayer released heroin. So when you get a huge glut in the supply, that can cause a public health crisis. It's happened at least twice in our recent history. So this is why this is a very unhelpful graph. Here's where we need to be. Whoops, sorry, that's too many times. Somewhere right about the middle. And it's unhelpful because I'm not going to give you very much advice at all. I'm going to accuse all these guys fix my problems for me. But basically, we might disagree about where this bracket goes exactly. Some people want to push it much closer to prohibition, And so there is a view that says, look, opioids are so dangerous and not nearly as effective as we'd like to think, so we should just not use them very much at all. And then there's another perspective that's like, drugs for everyone is pretty close to right, as long as we educated clinicians. Like, these are pretty safe and effective drugs, and you're letting people suffer, and pain is absolutely debilitating and life-limiting. So this can get pushed across the spectrum towards one pole or the end. But my claim is that if we want to be responsible, we have to take really seriously the idea that under-prescribing can be a harm and over-prescribing can be a harm. And these are in tension with one another, which is why this is a seriously hard moral dilemma. So here's my 3 sentences that I'm going to say about what I think responsible prescribing is. This is the conclusion of a lot of research that I'm not going to tell here because it's not my show. But I am going to put it up because I think it will resonate for folks who do prescribing, and maybe it will help us refer back during the conversation. So when I think about responsible prescribing, I say, look, one of the things we absolutely have to do is we have to initiate opioids when and only when appropriate. Right? So don't initiate them when they're not. Do initiate them when they are. So don't underprescribe and don't overprescribe. And for the reasonable amount. We're going to hear more about that from some of our speakers. The thing I want to point out is that piece of responsible prescribing is almost all the play. When you read in the media, you read in the scientific literature, it's really about, is this the right use of opioids and how many pills? But there's this other part, actually managing the opioids, because opioids have a couple of really tough properties: tolerance, dependence, and risk of addiction. That means that when you use them longer term, they actually change, and they have to be managed pretty carefully if you want to use them well. And it's a little too easy when you're treating acute pain, especially, to have a bit of a prescribe and forget mentality. You sign your name on a prescription pad, and your job as a prescriber is basically done. So here's a claim that I'm making that is not uncontroversial. Somebody's got to have this job for prescribing to be responsible. Somebody has to be in touch with the patient over the life of that prescription. And then this also involves appropriate discontinuation. Because since opioids cause tolerance and dependence, if you take them away too abruptly, it can cause withdrawal. Withdrawal can be harmful in itself. It can also be a punishment that feeds behavior that goes into addictive behavior and feed reward pathways that become pathological. Appropriate discontinuation is a really important part of making sure that people who are prescribed opioids don't become long-term opioid users if they don't need them, right? So that is basically all I'm going to say. For the rest of the panel, we're going to talk about orthopedics. And the reason I put these 2 pictures up is because I think there are different kinds of orthopedic surgeries that are worth having different sorts of conversations about. And I'm going to pick these folks' brains about. So we can have fairly routine surgeries. We can have surgeries like joint replacements that we do a lot. And routine surgeries have a particular virtue that we can plan them out pretty carefully. So here's a really important ethical question. How do we do that right? Every time we do a joint replacement in America, how do we make sure that the pain that it causes is appropriately managed without risking dependence and addiction? Right? But then there's other stuff, like this really gnarly foot. There's trauma, right? And trauma is hard because folks come in not knowing they're going to be there, and they might be in for multiple reconstruction surgeries, they might be in opioids for a really long time. So that's going to actually be a pretty significantly different situation. I hope we're going to talk about both of them. So with that, I'm going to pass it on to our first panelist. I'm going to introduce each of them as they come up, but Chad Brummett is an associate professor in the Department of Anesthesiology at the University of Michigan Medical School in the Division of Pain Medicine, and Chad's going to chat. Each of our panelists is going to talk for 7 to 10 minutes or so, introduce themselves and what their research has to do with this topic, and then we're going to open it up for conversation. I'm going to pepper them with questions, and I hope you all are going to pepper them with questions. Okay, thanks, Chad.
Thanks, it's a pleasure to be here. I am actually a Hopkins Pain Fellowship graduate, so I'm proud to be back here at Johns Hopkins. I'm going to say hi to my former faculty, Mike Erdig. And I apologize for not being able to hang around tomorrow. There is a good reason. We have actually created a new musical for opioids that's intended to teach kids about the risks and benefits of opioids. I'll be going tomorrow back to Michigan for one of the early performances to try to raise money around it, so I apologize for not being able to hang around because I do think the work that's going to happen tomorrow is important. So as Travis said, I'm an anesthesiologist, I'm a pain physician, and I've been cranking away on this space, this opioid space, really intensely for the last 3 years, but actually if I look at it, the entirety of my research career. And I reflect on the fact that when I started out, I thought 78 deaths per day was a lot, As Travis just noted, we're at around 130 deaths per day. This is one of the only public health problems that really gets worse. And you know, maybe we're plateauing, but we still have a long way to go. Our group came together around 2015, 2016. We really said, our thought at that time was that most of the country was focused on all the downstream effects, off to the right there. What to do with people with chronic pain, those with opioid use disorder, people already taking opioids, and all important topics, but at that time, really very few groups were talking about what to do with the person not using opioids. We could come back here tomorrow, and if you gave me 2 weeks of data from your hospital, from the weeks prior, I could predict who was going to get an opioid and how much opioid they get, just by knowing the surgeon caring for them and the surgery that they're having. Really, there's nothing tailored or precision about the way in which we prescribe. In fact, the only way in which we tailor opioids to an individual is if they're already on opioids. And so we thought this was an opportunity, rather than only focus on those patients using opioids, we needed to acknowledge outside of orthopedic surgery, if we think about general surgery, about 80 to 90% of the people coming in every day don't use opioids, and they haven't been our focus. And we thought this is an opportunity to think about that pathway as a preventive pathway. And really, honestly, in this era of the opioid epidemic, most of the focus in the CDC guidelines was really staged around primary care and pain medicine, because that's where the data were. But if you look at it, the relative contribution, these are national data, but over a 7-year period, the relative contribution of people not using opioids for a year, who gives them that next pill, the relative contribution of surgery is increasing. It's increasing year over year, as is dentistry. Not only is the relative contributions increasing, surgeons prescribe by far and above the most opioid per prescription. And so while the CDC guideline did a lot of positive things with primary care prescribing, we really saw this as an opportunity to focus on how people get their first prescription and really think about prevention. Now, as an anesthesiologist, it is kind of fun periodically, because they are my friends in Michigan Open, surgeons are my friends, but I get to tell surgeons what they're thinking. And as a pain physician, honestly, we think the same things. We worry about time, we worry about cost, we worry about satisfaction and phone calls for refill. These are all real things, and they drive care, and we know both through informal conversation and qualitative research, these factors have driven prescribing for surgeons, for dentists, for emergency medicine physicians, for primary care physicians. But there's good news. There's really no association. When we talk about surgery, and this is true for both general surgery and orthopedic surgery, there's really no association between the number of pills prescribed and people's satisfaction with their care. Nor is there any association between the number of pills prescribed and people's likelihood of refilling an opioid. Now, I'll unpack that. Are people periodically dissatisfied? Could you Google Brummett and find some patient that was angry because I didn't give them opioids at the clinic? I'm sure you could do that. And those one-off cases, unfortunately, drive care. But honestly, what drives prescribing and what drives satisfaction among patients is really that care we give to a patient. Do you call them after they call the clinic? Do they feel attended to? Those factors, does your check-in and check-out staff treat them well? And do they feel cared for? Not how many pills do they get. And we know this from our pain clinic, where we really had to focus on customer service and satisfaction for our patients, but not through more oxycodone, but instead through just better patient care. And we've seen year over year increases in our satisfaction, despite being a quaternary care pain clinic. In the same way, people refill after abdominal surgery about 7% of the time. But it doesn't matter whether you're talking about less than 6 pills of hydrocodone or more than 60, the refill rate's about 7%. In the same way, if we talk about total knee replacement, less than 15 pills of oxycodone or more than 150 pills of oxycodone, the line's flat. It's just higher. Many people refill after a total knee replacement, but there doesn't seem to be any association between that number of pills prescribed and that likelihood of refill. Now, while these were important to me, and I knew these were going to be important for surgeons to understand whether or not they could change prescribing, I was actually really interested in this concept of new persistent opioid use. How often does that patient coming in not using opioids in the year prior to surgery end up going on to becoming newly dependent, meaning that months later, long after normal surgical recovery, they're still using opioids? And actually, our first study in this space was really in total knee and total hip replacement. We had secondary data from an NIH-funded study where we had the gold standard measure of pain, stiffness, and function, the WOMAC, before surgery and 6 months later. And what we found was that among people not using opioids, and we really actually knew, we asked patients, we queried their medical record, 4% of the hips and 8% of the knees became newly dependent to opioids. And there's no association between whether their knee or hip got better, worse, or stayed the same and that likelihood of dependence. This was not simply post-surgical pain. In that same way, that top article there that we published in JAMA Surgery, we found that even after minor surgical conditions, about 6% of people became newly dependent, and there's no difference between major and minor surgery. And so what we could say, actually, if we wanted to be a bit more provocative, we could actually argue that becoming a new chronic opioid user is the most common complication after elective surgery, and yet a complication we haven't previously described to our patients. Now, we worked across the state, and we knew that if we were going to go around the state, actually lecture to surgeons and talk to providers about better prescribing, we had to know what was happening at the University of Michigan. And for those that don't know, we are leaders and the best. Well, when we looked at our prescribing compared to other hospitals around our state, we were leaders and the best. We prescribed by far more opioid than any other hospital in our state. And actually, we've now replicated that and shown that academic medical centers, Johns Hopkins probably included, prescribe more opioids than their private practice hospital peers. And PAs, nurse practitioners, prescribe about 19% more than their physician peers. And so we wanted to understand what's happening, so we said, let's do something simple. Let's look at gallbladder surgery. Super simple procedure, performed pretty similarly between patients. And what we found is we tasked a fourth-year med student, he's now one of our surgery residents. They said, find out how much people were being prescribed. We prescribed about 50 pills, between 45 and 50 pills after a lab chole. Now that should seem shocking, but sadly the first half of 2017, that's still pretty close to the national average. It's about 35, so for everybody who says this is all changed, it's all different now, they're just speaking from single academic medical centers. This is still common. We found that the median use was only about 6 pills. But 75% of people would have been satisfied with 15 pills, and we were early on. And for those that have done quality improvement or practice change, you know you can't mess up. And so we thought going from 50 to 15 would be a big deal. That's what we did. And what I love about surgery residents is if you tell them 15 pills, they write 15 pills. 14, 16, it's exactly 15. In fact, we should have been accused of fabricating data, but that became the new average, 15 pills. And what we saw was no change in patient calls for refill, 4% to begin with, 3% to follow. No change in self-reported pain. And then my favorite piece, when we gave them less, they actually took less medication. Now, it's only 2 pills. I'm not going to sit here and say, if we could reduce all prescribing by 2 pills, we're going to change the opioid epidemic. But now let's project this out to something more like knee or hip replacement or major spine surgery. And actually, we have replicated that, knee and hip replacement. For every extra pill you prescribe, patients consume an extra half pill with no improvement in pain, satisfaction, and refill requests. It's one of the strongest effects you can see. The amount you prescribe matters greatly. And so this is pretty simple. This is social psychology 101. This is anchoring and adjustment. Tonight Travis is going to take me out for dinner, I'm sure there will be a big plate of food. I will eat all of it because it will put in front of me. But if you gave me a smaller plate of food, I would eat that and I would be done. And I'm not saying that patients view opioids like candy. I don't want to be dismissive. But when you hand a person 90 pills and say, just take enough, here's enough so you won't run out, you're telling that person, this is going to hurt and you're going to need these. And I, like Travis, believe that there is balance and opioids have a role, but we have to be careful about sending the wrong message. So we now work across our state. We work through a very unique network from Blue Cross Blue Shield, where we actually have all 72 major hospitals in our state working together, both to feed data in and to disseminate data. And through this platform, we've made prescribing recommendations. I know you have prescribing recommendations from Johns Hopkins here as well. These are evidence-based prescribing recommendations based on patient-reported outcome, and they change. This is our 3rd iteration. We expect a 4th iteration soon. And so in each iteration, we add procedures, and over time, we've reduced. So you can see now with lap chole, we're getting down to 10 pills. I will tell you that next iteration will be even lower. We're starting to look like the Europeans in the way we prescribe. And we've actually looked at the effect of our work. So this is 35 hospitals across our state. This is the effect of sort of the first part of the graph there in black. The first downslope is our dog and pony show. This is us going around the state just talking about opioids. It did reduce prescribing faster than what we were seeing in other parts of the country. But then when given recommendations, when actually given specific prescribing recommendations, we saw massive increases in massive decreases in prescribing without any changes in pain or satisfaction. This is about 8,000 patients over 35 hospitals. So it just shows that this is an opportunity. We've now done this work as well in total knee, total hip replacement. So as I wrap up, what are the goals of Michigan Open? Well, we believe that new persistent opioid use is is a type of morbidity and a morbidity that can be avoided. And so we believe that through appropriate pain care that actually enables functional recovery, we can decrease persistent use. But I will say one of our new goals in this coming year and in the year to follow is really to look at all those cases where people are getting truly unnecessary exposures. So we have a lot of minor elective surgery where prescribing has become routine. We see percentages of patients that get opioids after cardiac catheterization, things where really you're talking about a single puncture site. We have really let opioids into every part of our medical system. Colonoscopies, people going home with opioids. So we can do all this, we can actually make change while still being safe and effective with patients. With that, thank you very much. I look forward to the discussion.
Thanks, Chad. So I decided what I'm going to do is I'm going to stay over here so I don't walk across every time. But you are welcome to go up to the podium for each of the remaining three, or stay here. Actually, stay here. Okay. So next we're going to hear from Dr. David Rain, who's Associate Dean for Comprehensive Care in the Department of Surgery and Perioperative Care, and a professor in the Department of Surgery and Perioperative Care at the University of Texas, Austin.
So I'm going to start off by saying I usually like to talk about safe and effective alleviation of pain rather than opioids, because I think that's having opioids at the center is why we're all in this room. But I will do it for this. And so when does that story start? Junior high. Remember health class? So I remember talking about the things that were dangerous. And we spent a lot of time talking about marijuana. Is it in that class or not? But cocaine and heroin were definitely in that class. You take them, they change your brain, your life is different. So then I went to medical school, and they taught me, yeah, if you take enough, you stop breathing and then you die. And if you take them non-medically, then you can get into a habit. And then if you take too much one night, you can overdose and die. So I thought, well, I guess I'll stay away from that, and I guess I'll have great respect for opioids, which is what they taught us to have in 89 and 93 when I was in medical school. And then I got to my internship, and I was a doctor, and I could prescribe stuff. Day one on the job, July 1, 1993, first assignment, go give a prescription for somebody being discharged, 90 Percocet. And I was like, this goes against everything I was taught. And I began to be, brought into the habits. And then as an intern, you are meeting a lot of people in pain, whether they're injured or ill with appendicitis or just had surgery. And the first thing that hits you, and it's not new because you've seen it in medical school, but an intern is just like really intense, is the huge variety with which people can interface with that and get comfortable. And so you have people sitting up in bed, smiling, walking around, taking almost no opioids or none at all. Then the same surgery down the hall, 10 out of 10 can't get comfortable, taking enough to fall asleep and then wake up and ask for more. And everybody else in between. And I took note of that, and I carried that forward. And then another thing that happens when you're at a place like Hopkins, I was at Mass General, there's a lot of people from other places. Anybody from another country in this audience? Got a couple. So one of my mentors was Jesse Jupiter, who's probably one of the most famous orthopedic surgeons in the world, and connected to this international group called AO. So he had people from all over the world come in and out, and I was doing research with him from internship. And the ones that were brave would speak up and say, you guys prescribe a lot of opioids. And what do you do? Like, you do a total hip on somebody, that's a pretty big surgery. What do you give them? Well, we give them ibuprofen. Well, that sounds mean. Oh, they do okay. So then I started to get into more and more research, and the next step of my learning was when patient-reported outcome measures came out. We didn't call them that. We called them, SF-36 was an iteration on the Nottingham Health Profile. We called them health status measures. But the idea is that we wanted to ask people and quantify, how are you feeling and how are you doing? And what are your symptoms like, and what are your limitations in your life? Can you be yourself? Can you fulfill your roles? Can you achieve your goals? That's what those are getting at. And in the late 1990s, when I was resident, going in, and then fellowship, the arm-specific one came out. And my mentor, Jesse, said, we gotta keep up, you gotta do this. So we gave it out to everybody. And I don't know, we were just giving it out to everybody like a range of motion or an x-ray. And then we had like 1,000 of them or 1,500 of them, and we just started to crunch the numbers. And I saw this, I made this histogram of dash scores, and it went from kind of heavy on the low scores and then all the way up to the really, really high scores and everything in between. And on this scale, if you have a score of 80, it's like you can't do anything with your arm, and it feels like it's on fire. I mean, it's like crisis. And this was for a single trigger finger. It's a very simple tendon problem. And I was like, there is no way pathophysiology explains that. And I started to talk about this. I'm having trouble understanding this. And I said it to somebody who had some psychology background and said, well, have you looked here? And so then we started measuring symptoms of depression, symptoms of anxiety. We started, they taught me about cognitive errors. Cognitive errors are the little mistakes your mind makes. It's what your system one makes mistakes. When your approximation, your first draft, your gut feeling, it's for danger. Use it for danger. You don't have time to think. It's your system one, according to Kahneman and Tversky. And the kind of cognitive errors that you make determine how comfortable you are and how adaptive you are to disease and dysfunction and injury. So they taught me that. We measured that. We hit gold. I mean, it explained a ton. And I was off and running. And then we said, okay, so we've looked at, we know that people in the Netherlands, where we have a lot of collaborators in a lot of the world, are not, they're getting their ankle fracture, they're having an ankle fracture, they're having it fixed, and they're taking Tylenol. But how are they doing? Are they suffering? So we asked them, and they're not suffering. Their satisfaction with pain relief, their pain intensity was the same as people getting a prescription for oxycodone in the United States. Same injuries, same surgery, done exactly the same. And then I said, well, we don't know what they're actually taking, so how can we do that? Well, right at this moment in the end of the 2000s, they had this thing where you were recording every drop of every medication that was taken in the hospital. So okay, then we can get every bit of opioids you're taking, and we can ask them how they're doing with their pain relief. And it turned out the more opioids that you took, the more pain you had. And it didn't matter how many fractures you had, and it didn't matter how severe the fracture was. And then what was making people comfortable? It was better thoughts. Better thoughts. So, man, my body's beat up. This is gonna stink for a while. My body needs time to heal. Everything will turn out okay. I can adapt to this. I'll be okay. Those thoughts were associated with more comfort. What's wrong? I hope I don't rip the stitches out. I wonder if I'll be able to get back to my life. Those worst case thoughts. If I move this, it could cause the plate to rip out. That's kinesiophobia, catastrophic thinking. That made for more discomfort. And of course, symptoms of depression was also there as well. And so it was your mindset, your support system, and your circumstances that got you comfortable. And it seemed to me that people were chasing comfort, emotional comfort, with more opioids. And then a couple of other things we did was we looked at who's still taking opioids, who's still requesting opioids a month after they broke a bone. So a month after the healing's pretty well established, who's still requesting opioids? Strongly associated with symptoms of post-traumatic stress disorder, symptoms of anxiety, symptoms of depression, and back to catastrophic thinking. It always comes to the top. So those thoughts that enter your mind that are not helpful, and they kind of stick there, and you ruminate and you feel helpless. That's what makes people want opioids. And if I look around, I look and see that not only the Surgeon Generals, this current one and the last one, have both put out a report on addiction in America. It's not just opioids. Alcohol's there. It's always been there. Cocaine and meth are higher than ever. And if you look at books like Dreamland and on these two Surgeon General reports, they make the case, which I think is pretty compelling and it fits my experience, that what we have is an epidemic of despair, of loss of meaning and purpose and connectedness. It's loneliness and despair. That's what's going on. And I think what we've done and what we do is we misdiagnose that and we inappropriately treat it.
Thank you, David. And we're going to move to Dr. Rachel Seymour as the Vice Chair of Research at Atrium Health Musculoskeletal Institute and Professor and Research Director for the Department of Orthopedic Surgery. It's a mouthful. I'm not going to get these words.
Thank you for having me. My background is public health, and I came to the Department of Orthopedic Surgery, and some of you may know it as Carolina's Medical Center. We're in a rebranding process, but we're the Department of Orthopedic Surgery at Carolina's Medical Center, and I joined the team in 2010. We do primarily orthopedic trauma studies, and as part of a really interesting multidisciplinary collaboration across emergency medicine, general surgery, trauma, orthopedic surgery, physical medicine, and rehab, that was internally funded by our organization to really kind of break down silos across the different departments. We had an opportunity to look at some cross-cutting issues, and we started in 2012 with some things that seemed obvious at the time, like concussion and geriatric trauma, focused primarily around falls. And then in 2013, when we got back together to say, well, what should the next big thing be, we pulled out the Epi data from the state and from across the country. And we saw the data that Travis showed us earlier with this uptick in unintentional poisoning. So we started really unpacking that and thinking through this and said, wow, this is something that as this group really focused on trauma and injury, we have an opportunity to make a difference here, even though coming out of the Department of Orthopedic Surgery at the time, it seemed a little strange that opioid would be our focus. Right around that time, we stumbled across a funding announcement from the CDC for the research on integration of injury prevention into health systems. And I'll tell you a little bit about our health system. We are a very large health system across North and South Carolina and now into Georgia. We have 45 or so hospitals, but importantly, we have 22 or so, the number changes daily, hospitals that are on a common electronic medical record, and another 500 care locations that include outpatient clinics, urgent cares, and freestanding emergency rooms. And so we thought this is a real opportunity to be able to do something with the guiding principles that we wanted something scalable, we wanted something that would be objective and evidence-based. Coming from public health, I should have known better. If only it were easy enough to give people information and change the world, we wouldn't have all the problems that we do. Giving people information is not enough, but giving people information was an important first step. So what we did with our initial round of CDC funding was we built a platform in our electronic medical record. We use Cerner, but really what we did was very technology agnostic. We used the tools that were just available in any EMR, rules, algorithms, and that kind of thing. And we first conducted a systematic literature review. We identified risk factors that were objective, that were typically found within the medical record and would be repeatable. So we synthesized these. We landed on early refills, so you've already got an open prescription and should have about 50% of those pills remaining. 2 or more on-site administrations of opioids at an emergency room or an urgent care within the previous 30 days. So some folks have tried to label that doctor shopping. We've tried to say, no, that is evidence that you have pain that is not being appropriately treated. 3 or more prescriptions kind of any size or duration within a 30-day period. A history of overdose of opioids within our healthcare system. And our EMR goes back to roughly about 2007. And then a history of a positive toxicology screen for either alcohol, cocaine, or marijuana. We did not include opioids because the number of patients who get opioids prior to toxicity being taken. This one was probably the one that we debated the most, but our addiction medicine specialist felt very strongly that any kind of history of misuse puts you at risk for misuse in the future. So with these 5 initial risk factors, we built an algorithm in the EMR that when a prescriber goes to click on an opioid or a benzodiazepine, if any of these 5 things are present, an alert pops up, like an allergy alert that you might get or any of the other alerts that says your patient has this relevant medical history that you should consider. It's not a hard stop. It doesn't prevent you from writing a prescription, but it does provide relevant information at the moment that you need it. This was our original platform, and we found that about 25% of people presenting to our facilities across all of the different types of care locations had at least one of these risk factors. In the orthopedic trauma population, it's higher than that. It varies, across different types of populations, but that's pretty significant. Our alert had about a 13% impact. About 13% of prescriptions were canceled at the time of prescription, which we thought was pretty good. We weren't necessarily looking for that. Our guiding principle has always been to balance safety and comfort, not necessarily eliminate prescriptions, but make sure that physicians and other prescribers have the information that they need when they write those prescriptions. We're then fortunate to partner with CDC moving forward when the guideline was released in 2016, and we did some additional work with our platform to operationalize those guidelines. And for some of you who may be at the sessions tomorrow, I have some information about how we did that and what that looks like. But we were able to package a lot of that information and be able to provide prescribers in our system with additional information. Why is this information relevant? What should I do now that I have this information? We created standard templates for pain agreements. A lot of tools and information that help prescribers prescribe safely. And that's really been our focus with our work. I was very happy to hear Dr. Wren mention some of these psychosocial issues and psychological issues. We've got some new work that we're doing now, doing some additional screening with depression and substance abuse in the acute care setting to address depression instead of chasing the wrong symptoms. So I look forward to answering a lot of questions.
Thank you, Rachel. All right, and last, but certainly not least, Dr. Seth Waldman is the Director of Pain Management Division at the Hospital for Special Surgery, and most importantly, from my perspective, he is a newly minted Master of Bioethics, so is uniquely situated to help us think through these issues. Oh, you got signed.
All right. Pardon me. Can you scroll through here? Okay, good. So I'm not a researcher. I'm a clinical anesthesiologist. I'm a pain management specialist. I've been in pain practice at Hospital for Special Surgery since 1994. So I'm one of those people who graduated of the generation where we were told to go out and spread the gospel that opioid pain medications were safe and were implemented at very high doses, which can be done successfully, but with substantial risk if you're not careful. And running the pain program at my hospital for a number of years, it became apparent that for a relatively small hospital, we were running into a lot of problems. We are an orthopedic hospital. We don't do heart surgery, we don't deliver babies, we do lots and lots of orthopedics all the time. And as a result, we end up with situations where we have patients who are coming on a high dose of opioids, patients who are impossible to control, a variety of different surgeons, different services. What I would like to do today, in just a couple of minutes I have, is to go quickly through a little bit of discussion about what was our challenge and then what the challenge the hospital gave to us in order to change things, and some things I think we're doing that are unique at Hospital for Special Surgery. So this is part of a larger talk about how we created the culture of opioid opioid stewardship at our hospital. Brief statistics about us: we have 130 orthopedic surgeons. We're doing 35,000 orthopedic surgeries a year. I'm going to skip through a lot of this because, frankly, I don't know that we have time. But one of the most important things was that we were sort of screaming into the wind about this for a number of years until one day in about December of 2016, our hospital administration said, we need some help. What do you need? And how can you help us to change things? And so our first step there was to obtain buy-in from the leadership. None of the things we were able to do at our hospital would have been possible, but for the fact that we had a tremendous amount of buy-in, not only from the hospital leadership and administration, but from the surgeons and from the internists and from the pain management doctors, the physician's assistants, the nurses, the nurse practitioners. Everyone recognized it was a problem, so it was, I won't say easy, but we had our work cut out for us. First step was to centralize responsibility. Once we had brought in the leadership of the hospital to be able to communicate to the remainder of the hospital what the statistics were. We won't go through them again. We've heard about the opioid epidemic, but this was sort of bombarding people. And Chad, you mentioned your Dog and Pony show. We had our version of the Dog and Pony show. We gave an hour-and-a-half lecture, myself and an attorney, to every single member of the hospital staff. I think we did it 18 or 20 times over and over and over again to make sure that everyone had heard the message. We developed an opioid task force, as most hospitals did. We tried to set some clear goals for how we wanted to proceed with this. And the most important things were that we didn't want to be overly draconian and terrify people. The goal here was not to stop people from prescribing opioids, and it's very easy to stop people from prescribing opioids. If you tell them we're watching you and we're going to see how many prescriptions you're writing, it's very easy for people to say, you know, thanks, I just won't write any. I'm not doing it anymore. Tell my patients to go somewhere else. And that's not our goal. Our goal is to understand the current state, to see what we can do to reduce unnecessary prescribing, to maintain safe prescribing, and then to work individually with our clinicians to make sure that they're getting the educational resources that they need. And it's a very labor-intensive thing, but it's ultimately an extremely productive thing to do in a hospital level. We had service-specific guidelines. I won't belabor the point except to say that we found the same thing as everybody else did, which is that we prescribed way too many pills. We were able to prescribe a lot less medication with no impact on our patient satisfaction scores. In fact, our patient satisfaction scores went up when we started to pay attention to this. And as a clinician on the floors, my sense of that is that the patients, except for a small population of people who were unhappy with the fact that they wanted more pills, the vast majority of the patients were happy that we were taking better care of them. They were happy that we were taking this seriously. They were happy that they didn't have to bring up the issue, you know, hey, what about these opioids? They knew that we were looking after their best interest. So we standardized prescribing practices. We tried to establish best practices in terms of our electronic medical record, tried to template smart phrases so that all the clinicians who were prescribing, documenting legitimate medical need, checking the state prescribing database, knowing how to use toxicology screens. We tried to facilitate the means of getting those toxicology screens done. Again, a lot more information to educate the workforce. I won't belabor the point. Some of these things were specifically for the purpose of getting our clinicians on board, but also to get the patients on board so that they knew that we were making these efforts as well. So as part of the preoperative education class, patients were also made aware of the fact that we were spending a lot of time paying attention to this and was for their own good. We developed something at HSS called the Preoperative Pain Screening Evaluation Service. And I think this is something which has made a huge difference. We gave a very simple set of criteria to the surgeon's offices and to the internists who were doing preoperative clearance. If you have a patient who's got more than 6 months of opioid use, if you have somebody who's got a current substance abuse disorder, or they have a history of illicit drug use, somebody who's got some kind of a prior complex pain history, like they had an intrathecal pump, or they've had a problem with pain control during a prior hospitalization, we want those patients to be seen by a pain specialist before you schedule surgery. We want to have the opportunity to meet with them. We want to have the opportunity to, you know, pre-hack them. You know, this is part of making sure that people are in as good conditions they can be when they come for elective surgery. And so those patients are all seen by our preoperative evaluation service. After they're identified, they are seen by a pain management physician, they're seen when necessary by a substance abuse psychologist. We have an opportunity then to slow things down a little bit. Unless it's an emergency, it's very important that statistic that you mentioned, Chad, about this is the most common postoperative complication. I think it's lost on a lot of people. It's true, and I think unless patients and surgeons are aware of that, they are looking at this as we're trying to slow down the machinery of the hospital. We're really not. So giving that opportunity to take a step back, call their prescriber, speak with the patient, get a toxicology screen. If they need to speak to a substance abuse counselor, we can identify something that needs treatment, we bring them in and make sure that they get treatment. And when that's all resolved, then that patient's cleared to proceed with an elective operation. When we can, we also try to mitigate the risk. If there are very high doses of opioids, when possible, we try to get them to taper opioids, because we're going to go from one high level to another high level to another high level. And this made a big difference. We have had a tremendous decrease in our length of stay for those patients who had preoperative evaluation. It's a huge benefit in terms of the staff and in terms of setting expectations, because not all, but the vast majority of those patients have a better understanding of why we're doing what we're doing, and they come with a more realistic set of goals rather than the varying set of goals that people have. Some people think that they're not going to be in any pain when they have orthopedic surgery, and of course we all know that that's not true. So we've reduced length of stay in some surgical services up to 35%. I want to talk just a little bit about monitoring. Every hospital is doing monitoring. Some hospital systems are obviously doing a much more extensive job, and we have a relatively small number of several hundred clinicians that we have to look after. But we began monitoring their prescribing habits, and the reason we began monitoring their prescribing habits is that people who are on the boundaries of their specialty for a specific diagnosis, for a specific surgery, are putting themselves, their patients, the hospital at risk. And we found that the best way to do this was by figuring out who those people were and educating them specifically. So we used our electronic health record to identify the top 10% of prescribers in the department, including departments that were surgical services, nurse practitioners, PAs as well. And we reviewed their charts. We went through physically, a section of their charts, and then met with them one-on-one and said, look, let's talk about this patient and this diagnosis, and what you wrote here, and what you wrote there, what you documented, and what you didn't document. And it enabled us to take graphs. I'll show you the graph for my division. This is the graph for the pain management division. This is our pre-state. And you can see there's a huge variability. I'm not provider 1, by the way, but I'm proud to say I'm neither of my provider number 8. So we want to have a lot of provider 4s. That doesn't necessarily mean that there's something wrong with that doctor. In fact, one of the things we learned by counseling people face-to-face, by meeting with them, is that we had the majority of our people who looked like provider number 1 were actually the best doctors we had in the hospital. They were prescribing a lot of opioids. They were also the most compassionate people. They were the people who were always trying to help their patients the most, and required a lot of sort of counseling, specific counseling, not only about what they were doing, what the risk of what they were doing was, but also counseling with regard to how they would deal with patient situations where they had to taper medications. I'll just skip to that next step. This is the documents that we use to counsel. Basically, this is very highly scripted behavior. The patient says X, and here are some things that you can say. The patient says Y, here are some things that you can say. Explaining the fact that tapering medication sometimes is based on good evidence rather than on trying to make the patient's life difficult. We have an ongoing monitoring process, which is basically a dashboard, and soon the clinicians will be able to access this themselves, showing that graph where they are with respect to their peers, with respect to the services they're providing, but also with respect just to documentation. So this is an example. It's very telling for somebody who in monitoring to say, look, we looked at all your charts. You don't ever document when you prescribe opioids. We have checked, and you don't ever check the state prescribing database. We've never ordered urine toxicology, and your amounts are higher than normal. We have a lot of work to do. And so we spend a lot of time counseling those people. And that's made a big difference for us. I think it's reproducible and scalable to larger systems. I think it's affordable, and in fact, I think ultimately it's not only the right thing to do, but it's cost-effective and safe. So, again, thanks. I hope I can answer some questions too during the panel.
Okay, so lightning round time. So I want to make sure we have time for you all. If you have questions, keep them. And I'm going to basically do one round of kind of lightning round. I'm going to give you a case, and basically I'm going to ask you all versions of the same question, which is how is your expertise going to help us with this even harder case, right? And then open up to you all, right? So I didn't used to do this. I didn't do anything with pain and opioids. I work on climate change ethics, which would not have me leading this panel. And the reason that all changed is because I took a motorcycle ride and got hit by a van. And so that foot that I actually showed on the trauma slide, I said, scheduled surgery, trauma surgery, that foot was my foot. And in case not all of you are really experienced reading X-rays, I'll just say that's not what a foot's supposed to look like. So the first metatarsal blew a big hole out through the inside of my foot, and I was in a limb salvage situation. So here's the case study for us. It's my case study. I have this intimate familiarity with two things that are really relevant. With really severe acute pain that lasts for a long time. So I had 6 surgeries total, 6 reconstruction surgeries. And I also have firsthand experience with the harms of opioids. And that's because my managing prescribers did not do a great job of taking the long view of prescribing. So the case goes, you have this limb salvage patient come through trauma, and what I needed was 3 orthopedic surgeries, pull the bone shards together. Still had this big problem that had turned into shrapnel and torn a hole out through my foot. So I had this plastic surgery emergency, had 2 first and attempted and aborted surgery, and then we did a free flap. So another big surgery, a lot of tissue from my thigh, plugged the hole in the foot. Lots of pain. It happened over the course of 4 weeks, 5 weeks before I got out of the ICU. All the time on escalating round-the-dose opioids. So very familiar with oral oxycodone, IV morphine, fentanyl, hydromorphone, eventually get gabapentin because they thought it was a great idea to clip a nerve out of my thigh. A whole other conversation about whether that was called for. So lots of familiarity with drugs. The dose increases thanks to tolerance. And I don't know this feature that everybody becomes dependent on opioids. So not everybody develops an addiction, right? A fairly small number of people develop an addiction, or addiction is just behavioral psychology. But everybody develops a dependence because that's how brains work. You flood the brain with opioids, it freaks out and says, this isn't a great state, try to reestablish homeostasis. And once it does, you need more to get the same analgesic or euphoric effects. So I'm developing dependence over a couple of months, and nobody's in charge of that. No one's driving that train. They're just giving me higher doses as long as I ask for them. And what am I doing as a good patient? I have these huge bottles of pills that I'm told to stay ahead of pain. So every 4 hours, I'm popping oxycodone as soon as I get home. 2 months out, I'm on 200 morphine milligram equivalents a day, gone from opioid naive to that in 2 months. And somebody, finally, the trauma surgeon, says, oh my God, this is bad news, get off the pills. And no one's driving that ship either. No one knows how to taper. So tapering was completely out of the skill set of my prescribing surgeon. And then when I called other people, because he gave me aggressive tapering advice and it sent me into withdrawal, my other clinicians didn't want to touch it. Because here I am shaking, sweating, in obvious withdrawal, saying I'm desperate, can you help me? And they see someone really complex. They might have various stigmatizing attitudes, right? And I can't get anyone to help me through this process. The end of that story is I spent 29 days in opioid withdrawal. And in a different talk, I would tell you all about the excruciating details of opioid withdrawal. But that's not this talk, thank God, because I don't like to tell that story very much. So when I come out of this and develop a kind of interest in doing research in this area, that's part of what leads to this idea that appropriate initiation is only one part of responsible prescribing. And a whole lot of what we just talked about is on that appropriate initiation. It's prescribing when it's appropriate, and making sure we don't give more pills than is necessary, right? There's this really hard problem, especially in, say, surgery, where the people who are in charge are making a ton of money per hour, and we're not paying for, say, tapering services. That's not a reimbursement code. And so are we really going to have orthopedic surgeons spending lots of their time on their own helping manage a prolonged tapering process. We're checking in every 2 days to make sure that they're not taking more pills than needed and not developing behavioral health problems. Because if we're not, then we need to understand that nobody's going to have these services if we don't assign them to somebody. So where does the management come in, and whose job is it to then do the deep prescribing at the end? Because those are the other two components of appropriate prescribing. So that's my broad question, and now given what everyone's here said, like my hope is you bring in enough smart people and put them on stage and you can just solve your problem for you, right? So lightning rounds, targeted questions. Chad, I'm a big fan of Michigan Open's work. I use it all the time. As you know, I wrote about it in my book, and I spread the gospel. Great scripts, all the data and the guidelines. It seems best suited for routine surgeries. It seems best suited for when the patient knows they're going to be in the hospital. They know that this is about what's going to happen. The surgeon can be trained on the intervention. What do we do? Have you got anyone who's working on trauma, who's working on the more unpredictable, long-term reconstructive surgeries?
Yeah, so the smartest member of our group is not here. That's Jennifer Walgie. Jen's a plastic surgeon, hand surgeon, and a bona fide health services researcher. And so we really took the strategy that if we could engage surgeons on what was easy and have success, that then we could have harder conversations. And that's actually borne out even better than I expected. Had we walked into these collaboratives, which include going to private hospitals, who really have a very different focus, if we had walked in and said, we want to talk to you about opioid use disorder, we want to talk about screening for opioid use disorder, or how to take care of the dependent patient, they would have really looked back and said, that's not my problem, right? And I still think today we have gaps. I won't say that in Michigan we're doing it all right, but I think we're starting to move down this path of asking those questions. How do we effectively screen for opioid use disorder? How do we start to quantify how much opioids people are taking? And then in the case like what you're talking about, how do we detect patients who have become dependent and think about tapering and tapering pathways? But we really are working on transitions of care a bit more, and those transitions of care are critical. That includes, though, however, I will say, I'm going to, again, acknowledge that the surgeons I work with agree with this. The challenge we have early on is that some surgeons didn't want to ask about diet, didn't want to check blood sugars years ago, because if you find a patient with diabetes, you have to manage that person's diabetes, cancel the case, right? And so now you talk about something that's infinitely more complex in opioids as use disorder. We had to move past that challenge and that stigma, and some of that's just pure education. But I really think that ultimately we have to engage primary care physicians, and we have to find ways to reward and compensate primary care physicians, because ultimately what we know, we published a paper on this in one of the medicine journals, that after about 3 months, the internists take them back. These become their patients, and so while they may not be excited about that on the front end, we believe that engaging what I would call the usual prescriber, in the case of a person who's using opioids beforehand, or the person who's going to manage them long term, and getting them involved early on, either on a person who's going off path or on a person who we've identified beforehand as high risk, is important. And those care pathways are incredibly challenging. And I think we have to be talking to more than just the physicians and the surgeons. I think that in most surgical spaces, the PAs do almost all the work. I mean, when we asked most surgeons early on how much do you prescribe, the honest ones gave me a blank look, because really their PAs or their residents did all of their prescribing. And so engaging that group of advanced practice practitioners who actually are remarkable for change when you put forth pathways. So, I don't want to pretend that we're doing something we're not. Your case would probably still happen in Michigan today. I hate to say that, it's true. I know it would happen in other states as well. But I think we are now poised to start to ask these questions, and we are actively, we have some SAMHSA funding currently to work on transition of care pathways, but it is, it's infinitely more complex than just the easy stuff that we worked on.
That's really sad. I thought we were going to be done. Rachel, so I was really interested to hear you say this alert pops up, right? This alert pops up in the EHR, because you built this algorithm. I want to combine that with something that Seth said, which is that it's really easy to scare doctors into not prescribing, right? Are you worried about that?
Yes and no. I think that was some of the initial discussion that we had, the 3 million committees we went through before we could get this actually built. Those were all the things that folks were worried about. And it turns out that it didn't scare people as much as we thought. I thought you were going to go somewhere a little bit different.
Answer the question I should have asked, please.
But no, I mean, I do think your case is incredibly complex. Actually, I wish my partner, Joe Shue, who's an orthopedic trauma surgeon and specialist in limb salvage, was here, because I think he would probably have a much more informed answer to this. But some of the stuff that we have done to really try to build out pathways for multimodal approaches to care, even starting in the inpatient setting, and focusing on not only other pharmaceutical approaches, but physical, cognitive strategies, particularly with patients that are going to be in for a long road. Where even the taper schedules that the OTA task force that some of us in this room were on offer, the case where you're coming back in for multiple surgeries time and time again becomes tricky with those taper schedules. And so, but having a lot of those tools and having those kinds of tools become more part of usual practice for all musculoskeletal related care, I would hope would have an impact even for patients who have a much more complex story.
Very interesting, thank you. So David, so my question to Rachel and you are less about the length of the trauma, which I was asking Chad about, but more about, I have this intimate familiarity with genuinely severe pain, right? On my first night in the hospital, I did one exact time I recorded a 10 on the pain scale. This pain scale is super weird, let's all acknowledge that. But that was one time where I thought, oh, I'm gonna die. Like, anything happens after this, it just kills me. Okay, so I'm intimately familiar with genuinely severe pain. So here's something that I deal with a lot, being someone who speaks a lot and writes for the public about this topic. I get called an anti-opioid zealot, right? There are really entrenched views on this topic, very passionate, very polarized, that's exactly right. And given the way I set it up, I should make it clear that even if there are anti-opioid zealots, I'm not one of them, right? I'm looking for the balance particularly. But I wonder, one of the refrains that gets happened a lot is, don't tell me my pain's all in my head, even though pain's all in your head, like that's where pain lives. But that when you're focusing on the psychological, when you're trying to make that move, you get called anti-opioid. How do you deal with that? You feel on this spectrum that I drew that maybe we should be pushed closer down.
Yeah, I know that people are thinking on saying anti-opioid because one of my partners, Tom Vetter, thought that, but he's figured out, he understands what I'm saying a little bit better. It is a very difficult message. I would ask you, if you don't mind. But first I will say to the audience, or I will reflect, that I think when we hear your story and see your x-ray, the words that come to mind are nightmare, living hell. I mean, we imagine, like, what if that was me? That's why whenever I talk about that ankle fracture study in the Netherlands and they took Tylenol, I mean, I'm not sure I'm okay with that. I think I might want to. So, but what I do know is, what I do wonder when I hear about your story is, anybody sit down with you?
Not once.
And talk about the emotions?
It doesn't even matter how your sentence ends. Not once. No one sat down.
So so I'll just drop the mic right there. So that's, and then the other thing would be, before I get into I think that answers the issue about like you said, pain is in the brain. There's a great video on YouTube called Understanding Pain in 5 Minutes. Check it out. Which is 100% truth in there. But one of the things I heard you were talking about is, like, they said, hey, take these, you gotta take these. And like Rachel said the word tools so many times. It's all about tools and strategies. And it's for the patient to get comfortable, and it's for the clinician to help them get comfortable and do the right thing. So what I see is, I do know the right dose of opioids. I know it. I hate guidelines. I hate fixed numbers. I like tools. But I do know the right dose. The right dose is the least you can possibly take. That's the right dose. So not zero, but the least you can possibly take. That's the one. Get off as soon as you can, and that's what you should do. So I think that's one of the tools and one of the strategies that helps people. One final thing about psychology, and Seth was referring to it. As somebody who's gotten interested in this, because that's where the data sent me, that's where the other experts kind of said, hey, look there, and they were right. It took a lot of time. It was hard to get orthopedic surgeons to take notice of it until bundles right? Once the money was here, you know, you can spend that on readmissions for pain, or you can have your quality score go down because somebody thinks their wound is infected. You go back to the operating room and manipulate the knee. You can do that if you like, or you can screen for depression and treat it before you schedule the surgery.
Great, thanks. All right, last one. Seth. We met a year and a half ago. I was up at special surgery with Levi, thanks for having me. And I gave, you know, a longer version of something like the talk I gave about balance, about responsible opioid use instead of minimizing opioid use or something like that. And one of the things we talked about is hospital for special surgery is an interesting institution because you do orthopedics day in, day out. You do so many of these routine surgeries. It could be a really interesting lab, right? And so I gave this talk about, you know, how do you follow up with a patient to do the management of de-prescribing? It's so hard. And if anybody could figure it out, maybe it would be you all, because you just do this all the time. And even in that room with our experts, it was like really hard to think about. Like, are we going to train up nurse practitioners to make these calls and give them the script? Like, what's the right solution? I'm wondering if you have thoughts on the kind of structural solution for an institution like yours or generalized.
Yeah, I have a lot of thoughts on the subject, some of which I hope we're going to get into in our session tomorrow, because there are several parts to this. Of course, the primary part is the patient and the patient's experience. The secondary part is surgical outcome, staff in the hospital taking care of the patient. There are a lot of logistic reasons why it's hard to find somebody who wants to take over your opioid treatment, or anyone's opioid treatment. There's a huge amount of pressure to prescribe opioids, and you don't know where it's going to come from. We were speaking about this earlier at lunch. Chances of being manipulated as a pain management specialist in order to provide opioids to somebody who doesn't need them is so high that I would venture all the pain management specialists in this room have at least a degree of post-traumatic stress disorder related to that conversation. It's a very, makes people very, very anxious. However, in the ideal circumstance, so you might be in the ideal circumstance, somebody who's not expected to be in that circumstance, but should be accept the conversation that you said in the presence of all animals. I have that conversation with every single patient that I know. Everybody gets, like it's too strong of a word, everyone gets medication, needs to know that I can make approval, tolerate opioids. They don't go around pharmacists, drug addicts, but they all become intolerant, they all get hydrosis, they don't want to use qualified use quickly, and that varies tremendously depending on the genetics and the circumstances and the psychology. So if somebody had sat down and had that conversation with you, and in a circumstance where you have multiple acute, you have chronic acute pain. In a chronic acute pain circumstance, if you have the right clinician working with you, anybody who's got the level of empathy and level of training specifically to the time to say, this is what's going on in your brain right now. I'm not saying it's all in your head, but part of it is in your head, and we're going to get you through this by escalating the narcotics when we have to, trying to reduce them when we can, and then when this is all over and you're going to do the go-to, and we're going to slowly withdraw these medications. That's an extremely time-consuming conversation. It can't be had by every clinician. It can't be had with every patient. Identifying people when we can, not in trauma circumstances ahead of time, is a huge difference. It's maybe the central component. I think it's the central component of this. But if somebody, I think, had sat down and talked, that was probably a word of all the problems. Your book was terrific. I said to you, I bought a copy of it for all my pain fellows. Everybody should read it. It can be horrible as a pain specialist.
I'll pay you later.
And, it's very hard to appreciate what people are really going through in that circumstance. But for a few minutes of talking, it really has been.
Thank you for that. We've got a few minutes for questions. So one thing I want to flag is that we're going to go out and have a reception after this. So all of us are going to be around. So questions immediately, and then we will also be happy to chat. Yes, sir.
Thanks, everybody. I've got a question for Dr. Ring. You talk about resilience and these psychosocial factors that can predispose to catastrophization, increase opioid requirements. Kind of a two-part question. One is, is this something that we can just kind of prognosticate, or is this something we can actually affect? And then I guess the second part of that is, is that something that's kind of a constitutional, immutable part of somebody's personality, or is that something that can be changed? And if so, what are some actionable things that providers can do to help patients along with that?
The less effective thoughts or cognitive errors, cognitive bias, is very responsive to things like derivatives of cognitive behavioral therapy. So think of it as exercises for your mind. So most of us understand the role of healthy activity, the role of healthy intake, healthy food and limited, no smoking and limited alcohol, stuff like that. I think it's time for a healthy mindset, and that it's an active thing that you do. You work on it every day. I mean, all of us who have succeeded in life have figured out how to do that, but we can all get better at it. So the evidence is that cognitive behavioral therapy is as good or better than medication and more lasting for mild to moderate depression, and it's super effective for kinesiophobia and catastrophic thinking. So it's great when you have discretionary surgery. In fact, what the evidence shows is if you work on that, you do rehab, then they don't want surgery anymore a lot of times. So that's beautiful. And then if they do have it, they recover a lot more smoothly. So I think that's where that is. And if they have an injury, expect it. Like, why do we not expect that to be depressing and scary and, what the heck is that? So I mean, in Mass General, the burn unit, because burn is sort of physically looks so awful, they had a psychiatrist consultant for years, for decades, and then to keep him, he did some trauma stuff as well. And I'm like, can you come up and see some orthopedic patients? And nobody wanted to pay for it. It was just so sad. Like, it was clear that it was a need. It was clear that it worked well, and nothing happened. So, is there an ingrained personality or genes or all that? Yes. Are there people who cannot, they have sort of, my psychology colleagues could do it better, but personality disorders are things that are not as responsive to, or just deeply ingrained habits. Like, they'll say that if you take somebody with back pain and do tests and surgeries and stuff on them for a year and hinder their development of effective coping strategies and let them develop ineffective ones, it's hard to salvage it. So you do, and then in that case, you just keep people in the embrace of care and make sure they don't get out and get unhelpful tests and unhelpful opioids and things. Just keep them in the embrace of care. Not going to win or succeed or nothing, but that's going to be the win, is that they trust you and they stick with you and they keep out of trouble.
Yes.
So I want to thank everybody for coming to Baltimore. I hope you have time for some crab cakes, and appreciate all your expertise. I have one question though. I'm a surgeon. When I walk out here today, what advice can you give me for tomorrow? What should I do? Give me something practical that I can do tomorrow that's going to make it good.
Sure. So I would say expectation management. First and foremost, talk to patients. We've gone for decades of telling patients, we talk about pain-free, opioids as painkillers. They don't kill pain. That describes an overwhelming benefit, right? And so I think setting the expectation that surgery hurts. It's going to hurt depending on what kind of surgery you do. It's going to hurt for the first day, maybe a few days, and then it's going to start to get better. I'm giving you these opioids as a tool. And I'm going to use ibuprofen and acetaminophen, and even though you can buy them over the counter at CVS, they're still effective analgesics. And those very, very simple things, right? Those simple things, but what's going to matter most is you speaking to them, framing expectations, and letting them know that if there's problems, you're there. And that is a big piece going forward. Surgeons and their PAs really do need to be there and available more often, and really head these things off before they get worse. I mean, Travis, your case is an extreme, but there were multiple touch points where I think things could have been steered in a different direction. And so not everything's going to go as planned, but your face, letting them know you care, your satisfaction scores will go up too. I'm sure people like it already though.
And Michigan Open has a lot of great resources, free open access online, that you can download scripts and that sort of thing. And then also, if you're not comfortable tapering opioids for routine dependence after 2 weeks or 3 weeks or whatever, the CDC has one, some nonprofits have them, kind of pocket guides that teach you, look, this is a pretty straightforward process unless they develop behavioral health psychology or they've been on opioids for years.
Hi, so my name is Mike Finger. I'm an internist in teaching medicine. None of you have mentioned buprenorphine, which is an incredibly useful tool. I could have helped Travis, I'm sure, And I think that anybody who prescribes opioids and then has a patient come to them and say, I've been on this for 2 weeks, I'm having trouble stopping, and it's much more effective to treat with buprenorphine for 3 to 5 days than to come up with a way of tapering other weeks.
And you're bringing up a very key issue, which is a little bit peripheral to the treatment of acute pain, but is a key aspect of this, is do we accept that when people have an opioid misuse disorder, or that they've been on opioids for 2 years for their pain and now are tolerant or dependent, do we accept that that's a chronic illness that's treated with buprenorphine, or do we think it's an issue of willpower and morality? That's important. And when people, we have people coming into our hospital in Austin because they've overdosed or hasn't had an infection or something, and we say, hey, we got them, you know, and they're like, this is a low point for them. How would you like to start recovering? We put them on buprenorphine as an inpatient, and we get them hooked up outpatient. And I think it's kind of recognizing that we blew it, and those brains are changed. Would you agree with that?
But I'm saying there are people who only need a few days. They don't have an opioid use disorder. It's just been on opiates too long.
Well, but that's a debate that we could have. You know, like, I mean, his was a few months, but if it's a few years, it very well may be an opioid use disorder.
But I see people with weeks and they've developed withdrawal.
I think the only challenge there is training that needs to be done, because you can, as you know, you can precipitate acute withdrawal. So if you take a patient using traditional mu agonists and they're still taking them, and you don't put them into a mild withdrawal before you start that bupe, you're going to have problems. And so I think there's training needed there. We use bupe. I like bupe. I think it's a great drug. I've created protocols that were probably problematic, and I've undone my protocols. But you know, I think it's a great drug. But it is one that is a distinct drug, and it requires special training. And you do have to think about how to induce buprenorphine.
Some of the new things that are important for our audience with surgeons, and if you can keep people on buprenorphine when you're doing post-operative thing, you have to take them off. That's key, because people relapse when you take them off. And it actually is a pain reliever.
Yeah, so we have to call it. I don't think we finished that conversation with Mike, but thankfully you're going to come for a part tomorrow, right? Yeah? Yeah, okay. We're going to hopefully get to pick Mike's brain a little bit more about buprenorphine tomorrow. Thank you all for coming, for sticking around. Your reward is food, and happy to chat more. Thanks so much for my fellow panelists.